Hello and welcome to GBA 1 Module 6 Pharmacy Benefits. This week we will be covering material that revolves around one of the costliest portions of a health plan benefit. We will explore the areas of pharmacy benefits, prescription plans, cost implications, and the role of the pharmacy benefits manager. Our learning objectives for this week are to describe how prescription drug plans operate and the ecosystem within which these plans function. Describe how various types and classes of drugs are treated differently within prescription plans and the cost implications for overall plan expense. Explain the cost management features embedded with prescription drug plan structures. Describe programmatic methods by which prescription drug plans enhance clinical outcomes and improve quality of care. And discuss the means used by pharmacy benefits firms to leverage efficiencies and cost savings for a prescription drug plan. As with the understanding of medical plans, we can take a historical look at pharmacy benefits and gain an understanding of how they evolved to present-day state. Pharmacy benefits started out as riders, a type of add-on, to medical plans much like vision and dental plans. Processing of claims required the participant to pay in full and then submit receipts for reimbursement. Cost of drug prices is a significant factor in the overall design of a pharmacy benefit program. In the 1970s, drug prices lagged the Consumer Price Index, making them very attractive to consumers. Demand for prescription medications led to an increase in drug prices exceeding the Consumer Price Index in the 1980s. It was at this juncture that insurance companies began unbundling drug benefits from major medical benefits. The escalating costs led the industry to search for lower cost alternatives globally due to the expense being much less in countries outside the United States. This brings us to present day, where prescription drug plans are a subsection of the medical benefit referred to as a carve-out. Different from the early days of prescription benefits, carve-outs do not require a separate filing by the member, as generally there is a pharmacy benefits manager or a third-party administrator that handles the processing. In order to understand the operation of prescription drug plans, there is a need to understand what is referred to as their ecosystem, or how prescription drugs fit in with other benefits such as medical, dental, and vision plans. This includes how drugs are categorized and distributed, how they're purchased across the supply chain, which includes manufacturers, wholesalers, and individuals, the design used to manage the plan, and the influence of the legal realm to include the Affordable Care Act and HIPAA. In looking at the fit with other medical benefits, prescription benefits are generally administered by a PBM or a TPA via a carve-out from major medical. Having the plan as a carve-out allows for discounts off of normal pharmacy charges, electronic claims administration, utilization reports, as there is a potential to receive cost reductions via programs such as mail order or internet services and manufacturer rebates. Although there are different designs of plans, common across most of them are the use of member eligibility cards, online claim adjudication, copay and deductible tiers, networks of providers, maximum allowable cost for use of generics, mail order service, formularies or preferred drug lists, prior authorization for certain high-cost medications, and therapeutic interchange or switching, which is moving to a different type of drug for better treatment outcomes. The design and management of a plan can come from public or private sources, such as insurance companies, for-profit and not-for-profit sources such as Blue Cross Blue Shield organizations, or via a pharmacy benefits manager or PBM. A PBM will only consider covering a group based on risk. This is generally measured by the number of lives that will be covered. Remember, insurance is based on a law of numbers. The common minimum amount is 2,000 lives. However, smaller organizations have been banding together into coalitions in order to have PBM administrators. Funding could be self-funding or fully insured, and many organizations choose to use reinsurance or stop-loss insurance to cover a particular amount to keep costs down. From the employer perspective of managing pharmacy benefit plans, there are certain considerations that must be thought through. For instance, They can administer the plan internally, which requires a very large number of lives to be feasible. They can outsource the plan to a PBM or TPA, or they can contract directly with pharmacies. In looking at the overall cost implications to a plan for expense purposes, several factors must be considered. Which drugs will be covered is a major consideration. What exclusions will apply, such as biotechnology medications, contraceptives, and lifestyle drugs? The latter are drugs that don't necessarily cure an illness but can improve daily life. Examples include weight loss medications and Viagra. Over-the-counter drugs are often excluded, with the exception of items such as insulin, needles and syringes, prenatal vitamins, and diabetic supplies. Some plans will cover various over-the-counter medications if the use of that drug will ward off something much more expensive later. For example, allergy medications, which could lead to higher hospital charges if not treated. Generally, alternative medications are not covered. How the ACA influences the design. A major factor of this law was the elimination of over-the-counter medications, with some exceptions from health reimbursement and spending accounts. Excuse me. What coverage disclosures to provide? Publication of the formulary, what is covered and what is not preferred. In general, the plan sponsor or the PBM can develop a unique formulary of what will be covered by the plan. Another consideration, capitation and risk sharing in pharmacy benefit management. Capitation is a method used for coverage where charges are based on a flat rate per participant. It has been hard to realize due to difficulties in finding cost equity across participants based on individual utilization rates of different drugs. Another consideration is the overall cost. Costs have gone up dramatically over the past few decades. Now, with the direct-to-consumer advertising, demand for various brand names has increased costs. The target market is the baby boomers, who are at the cusp of the age where various diseases reveal. Various drugs can delay or deter them. Finally, prescription drugs can be a substitute for more expensive behaviors. Overall, demand and cost has increased to the point where prescription drugs are 10 to 25% of the overall healthcare costs of the employer, necessitating securing the right PBM for cost controls. The trends in prescription drugs. In the environment of accelerated demand and cost, biotechnology drugs have emerged, creating a segment that is creating its own trend line. And how to structure co-payments. Though the amount paid by the enrollee can vary depending on how the structure is designed with respect to tiers, the use of generics, and the cost share design of preferred and non-preferred drugs. This is an important consideration. In order to control costs, a system of managed care and design is also evident in pharmacy benefits realm. These include factors such as gaining prior authorization for high-cost meds, setting parameters for quantity limits on certain drugs, monitoring the use of drugs, monitoring the cost factors of use and demand, using mail service programs, understanding what is referred to as pharmacoeconomics, engaging in utilization reviews, and designing and leveraging formularies that fit strategy. Pharmacy benefit cost factors include the demographics of the population, which relates to the point that certain diseases reside within certain groups. It also includes the things such as benefits, copays, and formulary design that drive what will be covered in the plan. Drug costs and mix are considered with respect to having certain drugs on a preferred list, having others with a high copay, and yet others not allowed. There are times where influence on this arises from whether a rebate is offered for a particular medication. Also, there is the utilization factor. How much is the plan used? Higher used, higher cost. The ability to make profit by using features such as mail order is significant. Costs can come through fraud from patients, pharmacies, or medical providers through misuse of prescriptions. This necessitates consideration of various controls. Finally, proper management is imperative to the overall cost of the plan. Tight management will be more cost effective than no management. Programs associated with union plans may be more costly, as collective bargaining processes may have negotiated much lower copays for union members, leaving the organization with more of a cost to pay. Utilization management relies on drug utilization, or DUR, which is a system of managed care that reviews drugs taken by the patient to validate whether it's the best choice. This review can be concurrent, taking place at a pharmacy, retrospective, which is the pharmacy case management done via nurses or pharmacists, or prospective, which is a program of educating physicians and patients about drugs and drug theory. There are various pros and cons to each, depending again on strategy and design. The formulary is a list of drugs preferred by health plan, and it generally centers on brand name drugs. There are 3 types: open, preferred, and closed formularies. The design comes from the evaluation and analysis conducted by a pharmacy and therapeutics committee, which is comprised of physicians, pharmacists, and nurses. Classifications of drugs on the formulary is based on the combination of the average wholesale price and any manufacturer rebates. Formularies have several pros, such as cost reduction and better patient utilization. However, there are also some cons, such as the time-consuming nature of communication of the plan to participants and the impact with changes that are made. Of great importance is getting physician support for the formulary, as they deal with a large number of different medications, and each plan may have a different formulary. Disease state management came about in the 1990s as a means of getting in front of many chronic diseases patients may have, such as diabetes. Getting in front of these type of conditions has been shown to reduce costs by eliminating trips to the emergency room and hospitalization. There are 2 models of disease state management: the medical model and the therapy-directed model. Understanding the return on investment of implementing a disease state management program requires periodic review of the program. In order to improve quality of care, many plans have turned to evidence-based medicine, where decisions are made based on what research and statistical methods reveal with respect to risk and outcomes of various treatments. This creates a robust engagement in formulary development, DUR, and comparison of various cost-effective therapies. Additionally, plans look for such factors as duplication of prescriptions to patients and various error detection, which include the edits showing such information as clinical information and drug interactions. This can alleviate negative effects of bad drug reactions that could lead to more costly hospitalization events. A pharmacy benefits manager is an entity that administers the managed pharmacy program. This type of design has increased over the years for ease of administration on the part of the plan sponsor or employer. It is important to review the costs of the PBM, the service they provide, how they generate profits, and what passbacks via rebates they give the plan sponsor. It is important to evaluate any conflict of management issues in relation to the PBM. For example, whether they have historical relationships with large drug chains or manufacturers, whether they're owned by independent pharmacy consortiums, who owns the PBM, and whether they give preferential treatment to specific products or pharmacies. This was a mouthful. So now, let's move on to Module 7, where we will take a look at behavioral health care benefits.